Good evening, everybody, and welcome to NBCA's April PEP Talk, Weight, Blood Clots, and GLP-1 Medications. I'm joined tonight by my PEP partner and 7-time blood clot survivor, Todd Robertson, who's not feeling so great tonight. But Todd, thanks for toughing it out and joining us this evening.
Of course.
And our clinical guest tonight is Dr. Rushad Patell, who some of you may know already. Dr. Patell is a benign hematologist at Beth Israel Deaconess Medical Center in Boston. He is also an assistant professor of medicine at Harvard Medical School. And he is the co-chair of the NBCA Council of Emerging Researchers in Thrombosis, and has worked actually with NBCA now for, gosh, maybe 5 years, about 5 years now, and really has developed the clinical model of shared decision-making with patients, between patients and clinicians. And I would love to see this rolled out, to all clinicians. Rushad, you've done such a great job working with the patient community, so thank you. And we want to thank you for joining us tonight as well.
Thanks for having me.
Thanks for joining. I'd also like to remind everyone, I know you saw it when you logged in, but we are not here to give medical advice. Tonight's PEP Talk is for educational purposes only, and we really do want you to consult your own doctor to talk about your own health experience, and we're hoping that we give you some tools to have that discussion with your clinician. Before we get started, I'm going to turn it back over to Todd. He's got some quick polling questions before we get going for tonight's topic. Todd?
Sounds good. Thank you, Leslie. And hello, everybody. And as soon as we get those popped up, I'm going to read them to you. And here you go. You know how to do this. Was the importance of losing weight ever discussed with you after your blood clot? Yes or no? Did you start a weight loss exercise program after your blood clot? Yes or no? Did your doctor have a discussion with you about using a GLP-1 to aid with weight loss? Yes or no? If you could answer those, we're going to read the results real quick, and then we're going to get into this fantastic episode that everybody's so excited to learn from. I'll read those to you in just a second. Okay, they should be popping up. Here we go. So let's review that first question. Was the importance of losing weight ever discussed with you after your blood clot? 29% said yes. 59% said no. Not available was 12%. Did you start a weight loss exercise program after your blood clot? 44% said yes. 43% said no. So that's kind of evened out. Did your doctor have a discussion with you about the GLP-1 drugs with aiding you with any weight loss? Only 14% said yes. 77% said no, Leslie. And those are the results. Thank you, folks.
That's interesting. It's also interesting, number 2, did you start a weight loss program? One of the things that, separate from this discussion tonight, we're working with Rushad, is actually trying to better understand clinicians and what they're sharing with patients about getting started with an exercise program. So we hope to share that with everybody in the next couple of months. Okay, so we're going to dispense with the niceties of calling you Dr. Patell, and we're going to go into Rushad, because that's what we're used to. And that's the format here on their PEP Talks. But so Rushad, you're actually one of the few hematologists that has done work in this space on the GLP-1s and the blood clots. Before we get into the research process, talk to us about a couple things. First, why carrying extra weight increases the chances of getting blood clots? Is it inflammation? Gene Connors used a term the other day, Dr. Connors, inflammaging, which I thought was interesting. And there's probably some relevancy with that too. And is it primarily related to abdominal fat, or does it really matter, if your BMI is high, it doesn't really matter where it goes? Like, talk to us about this inflammatory state, and how it actually damages blood vessels and activates the clotting cascade. And we've had some people refer to it as sluggish blood. So this is a 2-parter. So we'll start there, and then I'll give you the second part.
Thanks, Leslie. So the answer to your question, as you can imagine, is it's very complicated. But let's try and break it down a little bit. So, when we think about blood clots in general, or venous blood clots, because that's what we're focusing on, and I'm going to make the distinction because being obese or being overweight is clearly linked to arterial, like strokes and heart attacks, and most of us can sort of like quickly make that association. We've sort of heard about that a lot. It's related to like glucose metabolism, lipid, cholesterol, etc., and they all go together. But I'm trying to think of like now venous blood clots, so DVTs, deep vein thrombosis, often in the legs, but not always, and in the lungs. And in general, there's this classical way of sort of thinking about the pathophysiology of blood clots, and we think of it as, one is the blood itself. So you mentioned sluggishness, but we sort of think of it as, is the blood more likely to clot or coagulate? Is it a hypercoagulable sort of the blood and flow? Another one is sort of the endothelium, or the lining of the blood vessels. So I think of it, when I explain it to patients, I often call it like the Teflon coating, so the non-stick coating, sort of that prevents, clots that shouldn't be forming to sort of form there. And so like, does it affect that? And then like the third one is, is there not enough flow? Or rather, whenever blood sort of stagnates in the body, it increases the risk of it clotting. So it's meant to be a flowing liquid, but if it sort of stalls, then it can clot. And so now if we sort of bring in obesity in, and we say like, how does that affect, all three parameters that would increase the risk or affect the risk of a blood clot? Let's start with the last one, which is sort of maybe the easiest, is, when people are morbidly overweight or obese, they're less likely to move. So there's actually a clear link between like sort of mobility and being overweight. So there's that. Of course, being overweight or being obese carries in itself a risk of sort of being more likely to be hospitalized, more likely to have a stroke. So all that's also linked to sort of mobility and immobility, which is linked with increased risk of blood clots. Then we talk about like the lining, so the endothelium and the blood itself. The endothelium is the lining of the blood vessels, and the blood itself is more complicated. I mean, you mentioned the coagulation cascade, so that's basically a series of proteins that exist in the blood. They're usually not active, but as soon as they become active, they sort of start cutting each other and creating a chain reaction, which ultimately leads to a blood clot. There's another important player that floats around in the blood, and those are the platelets, which are tiny little blood cells that one of their crucial jobs is to actually form a clot when necessary. But both these the coagulation cascade, or the clotting proteins, and the platelets have seen to be affected by inflammation. And you said it. And being overweight or having extra adipose or fat tissue is linked to inflammation. In other words, adipose tissue is more inflammatory. It's pro-inflammatory. It increases sort of the general sort of inflammation in the body. And that does affect both the clotting proteins. It basically leads to an elevation of certain clotting proteins. It leads to more active clotting proteins, and it affects the function of platelets. Why and how we won't get into, but that sort of like is how it works. And then similarly, sort of the endothelium is actually quite actively linked with sort of glucose or glycemic control. It's linked to inflammation. And, there is actually lipid deposition in the subendothelial layer as well. And so it can affect the endothelium as well. So we believe, at least the current belief is that obesity is multifactorial in terms of how it can affect coagulation. There's actually a third aspect, or rather a fourth aspect, which is, now if you think outside the blood and the blood vessels itself, being overweight is linked to, say, certain financial disadvantaged populations, which means that they're less likely to get access to healthcare, which is actually linked, of course, to an increased risk of poor health outcomes, which include blood clots. And then there's, of course, how do you prevent and treat blood clots with anticoagulants? And then do they work the same in people that have a much higher BMI or are much bigger, and somebody who's much smaller? And the answer is they don't, which is also probably has a role to play in sort of like the blood clot. So it's pretty broad, but it seems to affect, how blood clots are formed, how blood clots are prevented, how blood clots are treated, and how people have access to both the diagnosis and treatment of blood clots, be it so indirectly. And so all that probably plays a role in how obesity affects blood clots.
I mean, it's really fascinating, and this is not my second part of the question, but I just want to make a comment about something that I read recently. I know we always talk a lot at NBCA about hospital-associated VTE and how it's thought that about half of all blood clots actually occur in a hospital or venous blood clots in a hospital or post-hospital setting. And if you're going in for surgery and you're overweight, the likelihood of getting a blood clot, unless you're anticoagulated, is so significantly higher. Like the numbers were shocking to me how much higher it is if you are significantly overweight. So pretty scary stuff. It's bad enough that we don't get enough information about hospital-associated blood clots, and then you add this on top of it. Okay, so the second part of my question for you is, we kind of throw these terms around, GLP-1, GLP-1s, et cetera, but what exactly is it? I'm guilty of this as well. I know what it is, but I don't know exactly what's in it, how does it work, et cetera. And how many different types of GLP-1s are there out there for people? And if there's anybody on the call tonight who has experience with the GLP-1s that wants to share a personal history with them, we're all ears.
Sounds good. So to answer your question, it's actually quite fascinating. I was doing some reading, sort of revising, if I may, for the webinar. The way GLP-1s were developed is as always fascinating, and it goes back decades. They've sort of come onto our lips and in the news, etc., more recently. But the truth is that these stories, like so much in science, starts like almost 2 or 3 decades ago. And so everybody sort of knows about insulin, and even though that was discovered many decades ago and its role in diabetes, but similar to insulin, there are actually many hormones that are all playing a role in trying to maintain sort of a normal glucose level, but also sort of the normal metabolism of the body. And one of them is actually this GLP, or the glucagon-like peptide. So it's actually a hormone that's secreted primarily by the endothelium, not the endothelium, the lining of the gut, so the intestine lining, but also by some cells in the pancreas and in fact some neurons. And it has, as you can imagine, has many, many different roles. But one of its roles is sort of it stimulates, for example, insulin secretion. It slows down the gut, and it sort of tries to bring down the glucose levels. Glucagon is like almost to be thought of like, if insulin is on one end, glucagon is another hormone that's on the other. So this GLP, the glucagon-like peptide, it blocks glucagon, it stimulates insulin, and overall its role seems to be to sort of normalize or harmonize glucose control. And that's how it was discovered, and that's how they found it. And it's a peptide, so everybody's producing it, or they should be producing it, and it's sort of stimulated when you take a meal. So the idea is, you sort of eat, and you release the GLP, the glucagon-like peptide, and that helps stimulate the insulin, as you can imagine. That helps bring the glucose down. It tries to block the glucagon, so that decreases the amount of glucose that you produce. And it also tries to like sort of slow down the gut in general. So it has a normal physiological role. So where does the glucagon-like peptide, like one, come in? So these are actually artificially synthesized, but they are very, very similar. So they try to mimic the GLP. So you could be like, why don't we just use GLP-1s themselves? Well, that's because they have a very, very short half-life. And so you'd have to like inject yourself like multiple times a day if you were trying to use the actual hormone itself. So they've developed like synthetic molecules that to some degree preserve the function of the GLP-1s, and they even mimic the structure of the GLP-1s, but they're much longer acting, and they stimulate the receptors for much longer. So whenever there's a hormone, there's usually a receptor. So, the GLP-1s have a GLP-1 receptor, which is how they do what they do, like make the cells do what they do. So the drugs that we're talking about, we think of them as, their technical name is GLP-1 receptor agonists. So they are drugs that resemble the GLP-1s, and because they resemble the GLP-1, the naturally occurring GLP-1, they can go and stimulate the receptor, but they're much longer acting and they have a much longer effect. And that was key, because you really don't want, the initial drugs were actually drugs that you had to dose yourself every day with, you to inject yourself every day, but people are less likely. It also made it harder to sort of have an oral version, because your gut would sort of like digest it, which is why most of the drugs are injectable, although as of course, they are coming up with, and in fact, some of them are already like available, but there are oral formulations of the same. Like most patients take the injections because the bioavailability, or rather the way they get into the bloodstream is it resembles sort of the way the natural GLP works. Now, there are more than one type of receptors. Again, this is like sort of a complex system of hormones. And in fact, so the GLP-1 receptors are the main receptors, but there are other receptors. And in fact, some of the newer agents are sort of targeting not just the GLP-1 receptors, but also others. And some of the effects, like weight loss, is actually seem to be more potent when you affect more than one receptor. So some of the newer agents actually have a more potent weight loss effect, and that's believed to be because it's not just targeting one receptor, it targets more than one receptor. You asked me how many like GLP-1s there are. I think you meant the drugs. And so there are several. I think I was counting this like 5 or 6, 5 at least in the US, but there are some that are only licensed in Europe and in China. But so the older ones had disadvantages, like they had to be treated with you every day, with less potent sort of weight loss effects. And we're sort of trying to overcome that. So the newer agents are more potent, they're more longer acting, they can be taken only once a week. They affect more than one receptor, and so they seem to have more potent weight loss effects. Remember, the drugs were actually developed as anti-diabetic agents because sort of that makes sense because they stimulate insulin release and have various effects on sort of glycemic control. And weight loss was almost seen as a side effect. Like it was sort of seen like as a plus. And when they realized that the weight loss was pretty potent, they've now been developed more for as a weight loss agent.
It's really interesting because I personally didn't realize that they'd been around for as long as they had been. And, they seem like they just kind of like appeared a couple of years ago, but that's not the case at all.
That's correct.
Okay.
And I think one of the breakthroughs was, interesting factoid is the Gila monster, which is a giant lizard. It used to eat really large meals, like an entire bird or an entire deer, but it never had glycemic surges. And it turns out it actually had a GLP-1 in its saliva. And it was and that's how they realized that drug could actually, this could be an agent or a drug that could be used. And the first GLP-1 was actually, that's how they developed it.
Oh, that's so interesting. Thank you. Todd?
Yeah, and I think it was like 3 years ago when my doctor, I was 270 pounds. I'm 197 today. I remember he wanted to put me on a weight loss injection, but my insurance wouldn't cover it. So I ended up having to go to a nutritionist and really work the hard way on it. And I just wonder how it would have went had I would have got that injection. But Dr. Patell, let's dive into the research. That's something that I'm really interested in hearing about. All the research you've done in the space. You are one of the few to have done this research. So can you kind of walk us through your research, take us through the process, what was happening within that research? I think you used a database of something like 558,000 patients. What were the outcomes? Can you talk to us about that?
Sure. I'm actually going to pull up some slides because I find it easier. Give me 1 second.
Todd, I'm just going to ask you to give a yell into that mic when you're speaking because it's very soft.
I'll try to raise my voice.
Perfect.
Are you guys seeing it sort of?
Yes.
Yes, perfect. So, I think this audience here, we're talking at a National Blood Clots Alliance meeting. Venous thromboembolism is very important. In fact, it's very frequent, 1 in 12. These are some of the estimates, as Leslie knows. We don't really have great estimates for venous thromboembolism, but one of the estimates is 1 in 12 can experience a VT during their lifetime. And of course, it has profound effects. Even the VT itself can take someone's life, but even survivors have post-thrombotic and post-PE syndrome. And what's very interesting is that the incidence of VT or the rates of VT actually have been increasing, even though our awareness and knowledge about it has increased as well. And one of the theories is this may be actually because obesity has been increasing as well over the last few decades. So we talked a little bit about obesity, but here are some numbers. Actually, obesity increases the risk of VTE by 2 to 3-fold. Because there are many, many risk factors for VTE. So obesity is what we consider to be a moderate risk factor for VTE. But it is one of the strongest lifestyle risk factors. In other words, it's considered to be something that you can modulate. And just because obesity is so frequent, even though obesity is not one of the strongest risk factors, for example, cancer is an extremely strong risk factor for VT, because obesity is just so common. Estimates on population levels suggest that almost 10 to 30% of all VTs can be attributed to obesity. So it's very, very important, particularly on the population level. And so, of course, we talked about GLP-1 RA. So this is our research. So we use this very large, giant data set, which essentially is like drawing data from hundreds of hospitals around the world. This is how we designed the study. So we looked at in this analysis, this is the one that's been published, and there are a few others that are not yet published. But in the one that's published, we looked at patients that were diagnosed with diabetes. So everyone had diabetes. We excluded patients that had had a prior VTE, that were on oral anticoagulation or prior AFib, and I'll explain why we had to do this. We excluded people that were on the GLP-1 RAs before the start of the study. Again, this is retrospective data, but you sort of make it as if you were looking at this prospectively. The main analysis had two cohorts. So in order to show something, you have to compare it with something else. So really what we did is we took these patients and we looked for patients with diabetes that were starting a GLP-1 RA or starting another anti-diabetic. And we chose DPP-4Is, which are a different class of anti-diabetic agents that are actually close to GLP-1 RAs, but not associated with the weight loss, which is why we chose that as the comparator. So the study starts when you start the new drug. And we followed these patients for 1 year. If people sort of switched, that was allowed because that's sort of like how it would happen naturally. And at the end of the year, we're sort of measuring how many people developed a VTE, either a DVT or a PE. And then I think I skipped. Yeah, here we go. So these curves are essentially showing us like what are the rates of developing VTE. So as you can see, in the blue is the cohort that started GLP-1 RAs, and in the red is the cohort that started the other agent, or the DPP-4Is. And what you can see is that the curves are sort of separating. In other words, there are much higher rates or significantly higher rates of VTE. So this is both PE and DVT in patients that are started on the DPP-4Is. And the GLP-1 RA curve is also going up, but it's lower. And there's this, when you can see white between the curves, it means that there is a significant difference. Otherwise, if there was no difference, they would just overlap. So because you can see the curves sort of separate, and then if you look at the statistics, if you're familiar with them, a hazard ratio of 0.8 sort of reflects that at any time point, there's about a 20% reduction in VTE in patients that started GLP-1 RAs compared to the other agent, the DPP-4Is. And a p-value sort of tells us that this is highly statistically significant. If you look at it in numbers, it's like 6.5 patients per 1,000 patients. If you look at 1,000 patients and follow them for a year, but 6.5 of them, so 6.5, would develop a VTE versus almost 8 patients with a DPP-4I. So there is a difference, and it is statistically significant. And yet we can talk about, how different is different, and is it important?
And just remind me again, if you could go back for a second, the DPP-4 is what exactly?
It is another anti-diabetic agent that works in a similar pathway of the GLP-1 RAs, but does not cause weight loss. So it's like weight loss is not known to affect.
Okay.
In the paper, I don't want to spend like 1 hour talking about our research. We then compared it to some agents that you might be more familiar with, something like metformin or insulin, and we saw the same effect.
Okay.
So, whenever you're trying to look at a rate, so can you imagine if we just had one curve, we just had the GLP-1 RA, you'd be like, well, people still are developing VTE. And that's what you sort of expect. If you take a group of patients, like patients that have diabetes, a lot of them here were overweight, they will develop VTE over time. So in order to show that a drug actually increases or decreases the effect, you have to compare it to something else. And that's why you have to choose a comparator.
Okay.
The other comparator is the DPP-4.
Okay. That's a pretty significant differential between the two.
Well, the curves look very different. I've heard arguments being like, well, the absolute numbers are not so high. And I would agree. We'll talk about this. I don't think GLP-1 RAs are as effective, say, as an anticoagulant, where you would expect the curves to be much different. But this is sort of not what the drugs are meant to do. So it's a very interesting signal to see that there is a reduction.
Although from a percentage standpoint, I think it is pretty meaningful.
Yes. And then this is, when you look at these as a forest plot, it's sort of looking at the same thing. But the main reason why I'm showing this to you is that the differences were seen both for PEs as well as DVTs. We often think of pulmonary embolism, although this is part of the same disease. PEs are often thought of as more severe or more serious parts of the VTE spectrum. And so it's interesting here to see that there was reduction in both PE and DVT. And the next slide actually looks at we did have patients of all BMIs within this, because remember, this is patients that had diabetes, not patients that were starting GLP-1s for obesity. And across the BMI, so whether you were like, very overweight at a BMI greater than 40, or you were actually in the normal BMI, which is 18.5 to 24.9, there was actually a reduction. So it didn't really matter what somebody's baseline BMI was or when they started. The GLP-1 drugs showed a reduction in VTE despite or in fact of the baseline BMI.
How do you interpret the lower BMI? Because that's a pretty significant differential.
Yes, and I think so that sort of points because, I get asked, so like, why is there a reduction? So like, what is causing it? And the whole reason why, and Leslie, you know the story, I got interested in this is I started one. Like Todd, I still consider myself to be heavy, but I was really heavy. I think I was 265 pounds. And I, my primary care was able to get the drug for me, and we started it. And I was amazed because I have been somebody who's been struggling with my weight my entire life, and to actually see something that finally works. Nutrition and exercise is super important, but I was doing all of that and spending hundreds of dollars on a personal trainer, which seemed to be not impacting the weighing scale at all. The agents did seem to work. And, knowing that obesity is a risk factor for VT, I was like, wait a minute, what if this actually reduces VT risk as well? That's sort of what inspired the study, quite honestly. And so when you see this, what it points to is it's probably not just the weight loss that's leading to the reduction in VTE risk. So, GLP-1s clearly have effects that are outside the reduction in weight, like its anti-inflammatory effect. Another thing that points to that is actually these curves. So, one of the things that I found very interesting is if you look down here, if somebody has been on these drugs will know that they actually take some time to work, mostly because you sort of start on a very low dose and then you have to gradually go up because otherwise you'll get severe side effects. So there's not much weight loss that you actually see in the first few weeks or months. So if this is day 100, so this is like roughly 3 months, but the reduction in VT, the curve starts separating almost a week or two after you start drugs. So that again points that it's not just reduction in weight that's probably leading to this difference. And there's something about the drugs themselves and how they work that's probably leading to a reduction. I think these are interesting hypotheses. Where when we're trying to sort of like start some sort of translational work where we actually take samples to figure out like why is this happening, and maybe that'll lead to some like more insightful leads that can then help us for VT in general. But this story sort of supports it again. Another thing that supports it is we're seeing it across BMIs, and even in the very, very sort of in people that completely normal BMI to start with, the reduction was actually the highest, 0.61, so 40% reduction there. We also saw that in like the 35 to 40 BMI.
Mm-hmm.
And you don't see this much, but the numbers shrink with very high BMI. There are less patients with very high BMI in this cohort.
Is there a difference between men and women in the groups?
We didn't see a difference. We did look for it. We did not see a difference in those subgroups.
Interesting.
And I will say, like, for this sort of abbreviated presentation, I stuck to the primary. But, you must also think of like, well, what if DPP-4Is, they're not known to, but what if they increase the risk of VTE? You'd still see these sort of signals, which is why you have to compare them then in various different groups, which is why we sort of compared GLP-1s then to metformin and GLP-1s to insulin and GLP-1s to other agents, just to make sure it wasn't actually the comparator that was leading to the reduction. It was truly the GLP-1 effect. I think, yes. So like sort of the conclusion here was that there was about a 20% reduction, and we observed reductions across different BMI subgroups, regardless of their baseline obesity status.
It's quite incredible. Is there going to be any follow-up work on this from you?
Yes, in fact, there already has been. So, something that is not published yet, but that was presented last month, is we actually looked at patients with breast cancer specifically. As you know, Leslie, I have this cancer is a very high, very strong risk factor for thrombosis. And breast cancer patients, fortunately, they often live for many years now with our new treatments. But one of the treatments that we use are endocrine therapies, and they are linked with increased risk for both venous and arterial clots. And so we sort of said, what if we look at patients with breast cancer? And we saw actually very interesting results. There was a reduction both in arterial and venous clots in patients that started GLP-1s. We actually have two other studies. Sort of here we looked at patients with diabetes as a baseline and compared it to an anti-diabetic. We have another study that's yet to be presented, but it's been accepted for ISTH. So I can't tell you too much about it, but we basically looked at patients that are starting GLP-1s actually for obesity itself and compared it then. The problem with that study is like there is no highly effective obesity drug to like compare it with. So we tried, with the current the other anti-obesity drugs and then with bariatric surgery. And we got some results that more or less, I would say, are consistent. It seems like there is a clear signal that so far in these retrospective studies that the GLP-1s are associated with a reduction in venous thrombosis or risk.
It's amazing. I have so many questions for you, but I want to be mindful of time here as well. I'm curious, just so everybody knows, we're seeing your comments and questions come in. We are going to save time at the end to hopefully go through a whole bunch of these. So if we're not answering you, that's why, but we are seeing all the comments coming in. Rushad, can you comment on how much weight you've lost again? Over what period of time? And are you still taking the medication?
Sure. I have lost 35 pounds, and it's been a year, or at least, yes, almost exactly a year, and I didn't see any change for 3 to 4 months. If anybody's just starting, I was very impatient to begin with. I was like, what is this? This is water or saline that I'm injecting, but no, it does work. It takes some time, and that's the experience for most people on the drugs. Yeah. Now, I think one of the questions I've already seen in the comments is like, how long will you be taking it? I think that's an open question. There has been a lot of talk about like, and it was my biggest question. I was reluctant to start because I was like, well, what am I going to do with it in the long run? And I think the way the drugs are designed is that they are chronic medicines and you have to take them for like a long time. I think of it, I sort of had to convince myself, and this is how I've convinced myself. I was like, if I had diabetes or high blood pressure, which fortunately I didn't, but if I'd stayed at that weight, I probably would in a few years or in a decade or two. I would be taking drugs, and usually those drugs are taken continuously. And so, I think if you think of obesity as a chronic disease, which it very much is, it is not crazy to think that you might need, if you need medications to control it, that you might need them long term. And I think that's sort of how we're thinking about it. But I would say it's I think patients' biggest concern, and I think it's very relevant.
Well, we'll be looking forward to the other research that you're doing for you to share it with all of us. So let's get into a couple of questions here. So if a person who has already had a blood clot decides to take the GLP-1 medication and they're on a blood thinner, does the GLP-1 interact negatively with an anticoagulant, either a DOAC or warfarin?
That's a great question. So we talked about my research. One thing I mentioned is we excluded patients that had a prior VTE and we excluded patients that were on anticoagulants. And that was not because we thought of an interaction. That was purely study design. So when you're designing studies like this, it's sometimes hard to like pick up somebody who had a history of VTE versus a new VTE because you're not actually following them. These are like retrospective studies. So if you've had a VTE and if somebody codes or bills for the history of VTE, it looks like somebody had a new VTE. So the easiest thing to do is just exclude everybody that's ever had a VTE. However, that then leads you to this question as a very relevant population of somebody who's had a prior VTE. So I'll answer your question easily, which is, we do not believe that there are drug-drug interactions with anticoagulants. And that's principally because of the way the drug works. Remember, it's a peptide, which means it's a protein. It's quite similar to what the natural protein is. The drugs that usually cause interactions of drugs are things that sort of affect the metabolism of other drugs, and this one doesn't. The one concern that is logical is that, one of the ways it works is it actually slows down your stomach emptying and your gut emptying, and it sort of makes you feel full for longer. So there could be a theoretical concern of like absorption, because obviously absorption, when you're taking a pill, like if you're on warfarin or a DOAC, you rely on your gut to absorb it. This does not seem to be playing out like in clinical practice or in anything that we see or in research. I did see one abstract talking about warfarin. Warfarin is a good drug because you can like look at the levels, and so people were like, are the levels affected when you start a GLP-1? And the short answer is it doesn't look like it.
Interesting. Okay. And then second question is, what about different populations? So someone who has a genetic predisposition for clotting or has APS, or even somebody who's pregnant?
So I do not believe these drugs can be actually used during pregnancy. So like I will start there. So most drugs have to be sort of tested, and they have to be vigorously tested in a pregnant population. That's because you're worried about effects on a fetus. For example, DOACs are not used during pregnancy either. And so I don't think we know, and we will probably not know unless somebody actually, has to. Then the FDA is very, very strict about what you can do during pregnancy in terms of studies. But your other questions, I think I have to confess, so I have to admit, and I'm pretty sure that there is no data. We certainly did not look at patients with, hereditary prothrombotic syndromes or acquired prothrombotic syndromes like antiphospholipid, but there isn't any reason to believe that the signals would be different. In other words, the way the drugs work, they're mimicking a natural peptide. If it's related to weight loss, we do not believe that there is a difference in the type of weight loss in somebody who has a hereditary thrombophilia or has an autoimmune disease like antiphospholipid antibody syndrome. We have looked at cancer, which is an important risk factor, and we do seem to be seeing the signal, like I mentioned, and that abstract was actually already presented, so that's why I'm talking about it. So I think my gut is telling me that it probably goes, but I think those are very important questions and highly relevant, and ones that we are planning to look at. The problem is, as soon as you start sort of looking at subpopulations, you need it's harder and harder to find a group of patients in a study like this. And so you need a certain population, especially when you're trying to look at relatively small differences, like like again 7 in 1,000 is not very high. It just means you need a very large population to actually show a difference. And so I think that's the that is the issue with looking at.
But one of the big questions we had was, does it interact negatively with an anticoagulant? And the answer to that is no.
No.
Okay, great. I also just want to remind people, so we are not advocating don't exercise, don't live a healthy lifestyle. We're really trying to get information about these GLP-1s because, if it does have an impact, we want people to have the information and have the conversation with their clinician about this. And I know you spoke with your PCP about it, but is that who people should be going to, or do they go to an endocrinologist, or?
Well, I think you start with your PCP. Some PCPs seem to be much more comfortable with it, like mine, and I feel like I'm quite fortunate. But a lot of people do get sent to obesity specialists, actually, who are often endocrinologists or they're internal medicine people that have done a sub-board in obesity medicine. So I think either or. The drugs are becoming very commonly used, and so primary care physicians, I think, will gradually be extremely comfortable. That's how my PCP got comfortable with it. So yes, I think you start with your PCP, ask them if you're interested, whether they think you qualify. They might send you somewhere. There are insurance. I know there were a bunch of questions, and there are certain prerequisitions. Like the drug is supposed to be used in conjunction with exercise and nutritional balance, and so they often require you to have some sort of a weight loss program even before you start it for X number of months. And then your BMI has to be high enough. So somebody like me who had been, 3 years, 4 years, spending hundreds of dollars on a personal trainer and honestly trying and not really getting to their goal weight was like, it took not much, frankly, for him to put me on it. But I know others that have to go onto a program and then, which is good for them anyway, and which they need to do on the drug in any case. And then they start the drug. So sort of depends.
Okay. There's some really great questions that we want to get to, but Todd, I want to turn it over to you.
Yeah, and I made some adjustments here. Does that sound any better?
Oh, that's perfect.
Okay, that's great. Yeah, and I do want to mention just real quick, one of the best decisions, Dr. Patel, that I made was seeing a nutritionist. And even if that injection would have been covered by insurance, I learned so much from going to the nutritionist that sticking with that, I mean, you can't outwork a bad diet in the gym, right? You got to have some nutritional knowledge up there, and that was one of my favorite things was learning from that nutritionist. But we have a lot of patients in the support group who have surgeries planned or have been talking with their doctor about surgeries. And we, as Leslie touched on earlier, we know that half of all blood clots occur in a hospital or post-hospital setting, right? So If obesity is a risk factor and you are planning to go in for surgery of some kind, of any kind, do you recommend that people who have been trying to lose weight through diet and exercise but are having a hard time losing the weight try the GLP-1s before surgery?
I don't think I have a strong clinical recommendation because something like that really, but I will say it actually, the interesting link is when you're going to have surgery, you need to you always have anesthesia, obviously.
Mhm.
And one of the more common forms of anesthesia is actually general anesthesia, which requires somebody to be intubated. Actually, the GLP-1s, the strongest suggestion with surgery is you must make sure they stop it right before the surgery or the week before the surgery or at least 3 days before the surgery, because there's actually a risk of aspiration when you go in for anesthesia. I know that's not your question, Todd, but I think I must mention that because you're sort of bringing up GLP-1s and surgery. And I know from my anesthesia colleagues, the one thing they noticed is they were having so much aspiration, which is when the food sort of goes up and goes into the lungs, which is a dreaded complication of anesthesia. And they were like, what is going on? And it turns out, the GLP-1s, the food stays in the stomach for so much longer. So the usual, do not eat for 6 hours often has to be like 12 hours or 18 hours because you want that food to go out of the stomach, or you just don't take the drug for at least
Right.
3 to 4 days before the surgery. To answer your question, I think losing weight is always a good idea. That's sort of like what motivated me to get onto it. Besides, we're talking about blood clots here, but as everyone knows, there are so many advantages. It's probably the number one thing that somebody can do, no matter, unless you're at a healthy weight or underweight, but even being slightly overweight, losing that 5 pounds can actually impact cardiovascular health quite significantly. And cardiovascular health, vascular includes actually venous thromboembolism. So I think that's true. The complication rates are linked to having a higher BMI. But again, GLP-1s don't work fast. And so, you'd have to start 6 months to 12 months earlier to lose the weight. So I don't think it's something that I would think of as a short-term thing, as trying to go into surgery, more than a long-term chronic approach to being healthy / being healthier, which includes losing weight. And when it comes to surgery, I think the most important thing people must remember, and hopefully your surgeon and anesthesiologist will tell you when you go for the pre-op, is actually making sure you stop it in time before the surgery. Because that can be a pretty life-threatening sort of
Yeah, I didn't realize that. That's a very important thing for people to be aware of. But I mean, if you're planning for, hip and knee surgery are such catalysts for blood clots, if you're planning to have surgery and you need to, drop weight beforehand, being able to think about scheduling 6
Totally.
months, down the road.
And then again, actually being lighter goes beyond blood clots for hip and knees, post hip and knees, physical therapy, immobilization. The lighter you are, the easier it is to actually rehabilitate and reduce VTE risk. So you're absolutely right. So yes, but this is the funny thing about weight loss. It's probably a good idea always. And so I don't think we have to wait for a surgery necessarily, but yes, it would be advantageous to be lighter around the time.
Okay. I mean, we could go on and on with this because we have so many questions and this is so interesting, but we want to open it up for as many questions as possible we can get through tonight. So great question here. What if you were not on an anticoagulant, but have a history of clotting? Are there risks of clotting related to this?
So if I'm understanding this question correctly, so we saw a reduction in VTE, sort of, these were people that we actually excluded who had a prior history of VTE or were on anticoagulants. And so when you have a history of VTE, and particularly if you're not on an anticoagulant, your baseline risk is higher. I think you'd expect to see that risk go down with loss of weight and possibly with GLP-1s. I will say, though, I am sort of extrapolating based on the limited data we have, which is the data you saw already. And I don't have data to actually support that answer, but that's what I think would happen. And I think it supports it. I would caution, this is sort of what I was trying to say, is that even though you see a reduction in risk, this is not a substitute for an anticoagulant. And I don't think it should be seen as that. I think that's the only danger when you start doing studies like this. Is if somebody's starting a GLP-1, I would not recommend that they stop their anticoagulant because they feel like they're adequately protected. I certainly don't think there's data for that. And I think that would potentially cause much more harm than good. So I must say that out loud. That's what I think.
Okay. I mean, somebody also mentioned sleep apnea. So, that also is we all know the dangers related to that longer term, and it appears that it actually has an impact on stopping sleep apnea as well.
Yeah, tirzepatide actually is as an indication now for as treatment for sleep apnea. I will say, yeah, my boyfriend's much happier now that I'm lighter and on it and not snoring as much. So yes, um, it is. I don't know if there's a strong link between sleep apnea and VTE, not one that I'm aware of. But again, this is like, how weight can have sort of an impact on much more than blood clots, of course.
Yeah, for sure. Todd?
Are there any special considerations for those with genetic predispositions to clotting, considering the weight loss medication? A lot of folks with factor V Leiden who are either hetero or homo, they're concerned about that. Should they be concerned?
So I think, again, what we've demonstrated in all the data that we have so far, and again, we're trying to get more data and different types of data sources to sort of like confirm and prove it, suggests that that the GLP-1s are associated with a reduction in VTE. People that have hereditary thrombophilias or factor V Leiden, prothrombin gene, have a higher baseline risk. And so the hope would be that if you start at a higher risk, there's a reduction in risk that actually leads to an improvement. We don't generally, unless you've had a prior VTE, for example, etc., recommend people who are heterozygous for factor V Leiden go on anticoagulation, like, from the get-go. So I actually think like being at a healthy weight, reducing all your other risk factors, is a way of trying to modulate that risk. And so I see this actually as part of that paradigm. So, what happens if your mother, for example, had a blood clot and was tested for factor V Leiden, and then you went and got tested and found you're also positive for factor V Leiden, but you've never had a clot before. If you came to my clinic, I wouldn't necessarily recommend that you just go on a Pixaban or an anticoagulant just to prevent a clot anytime in the future. What I would do is educate you about VTE, direct you to the National Blood Clot Alliance website, Leslie. I always do it now, and tell them, go and educate yourself about blood clots, and you should know what the risk factors are, and you should know like what the signs and symptoms are. And I also tell them that, you really don't want to accumulate any other risk factors. And one of them, that so far, like, I wouldn't tell people go lose weight, because like I know myself how hard it is. I would say it, but then I wouldn't like harp on about it. But now you sort of have an effective way that's been proven that clearly works. And so maybe that's where this comes in a little bit. Again, there are many reasons to lose weight, but if you have a higher baseline risk of VTE, you probably want to do as much as you can to reduce the other risk factors. And so that may be where this actually comes in.
Are there any side effects of it? I know some people have commented that, they had nausea or some other side effects, but as it's kind of being, I'm assuming that, they continue to improve the GLPs. And so are there side effects?
Yes, this question reminds me of my mother. When I told her I'm taking a drug to lose weight, she told me, go to the gym. You're absolutely not taking medications and the easy way out, because who knows what the side effects are. But the good thing about the GLP-1s, they've been around for a long time. They've been in many, many randomized controlled trials. So actually their side effect profiles are well studied. And again, they're not new drugs, Leslie, to your point. People have been on them for years for diabetes, actually. So yes, of course, there are side effects. The commonest ones, the ones that almost that you expect, are nausea and constipation. They're relatively easy to manage. People usually get used to them. In other words, the side effects sort of mitigate over time. So they're pretty severe in the beginning, but they go away. It's actually why you start at a very low dose. So all these drugs are brought up slowly over, like, you take the same dose for about 4 weeks, then you go up, you take the same dose for 4 weeks. I'm just giving you an example. You go up. And the reason is, if you just start at the highest dose, you'll have like severe nausea and constipation. You won't be able to stay on the drug. But if you let your body sort of get used to higher and higher doses, the side effects go away. There are others, like gallstone issues and gallbladder issues are one. Pancreatitis is probably one of the, that's not so uncommon, but can be pretty bad. Again, these are like gut drugs. And so they can cause, and so like, my doctor, for example, told me to avoid binge drinking on the drug, because that's something that is actually associated with pancreatitis as well. So again, you don't want to sort of like, accumulate risk factors for pancreatitis. And I have personally known people, and pancreatitis is a very painful side effect. a very painful disease. I saw this question too. That is true. Like, in very large data sets, this optic neuritis sort of has been brought up. I will say that's a very rare. There does seem to be some signal for it, but it's extremely uncommon, like in general. And if you take a very, very rare side effect, and if you then try and look at like a slight increase in it, even if it's statistically significant, I think like the absolute risk is like extremely low, but it's known. So sort of anybody who has visual disturbances on the drug needs to like stop it, go to your doctor, make sure that that's not happening. I think medullary thyroid cancer, which is another extremely rare form of thyroid cancer, was reported sort of like early on.
Yes,
It
I remember
actually
that.
carries, you sort of like, if you've had history of thyroid cancer or if anybody in the family, there are certain sort of inherited diseases that do not go with factor V lipoprothrombin gene, completely different. They're called like MEN. If you have history of that or family history of that, it's not advised to go on the drugs because of this like risk of medullary thyroid cancer. But these are honestly very, very rare sort of like things that you need to be aware of, or that and before you start it, your doctor usually asks you about these risk factors and discusses. By far the commonest is nausea. And I know people that go to the gastroenterologist because they're having like severe nausea, but that's how the drug, that's sort of like part of like what you expect. And so you might have to like back off, go back down on a dose for another month, stay on that same dose, and you gradually build tolerance for the drug. There are people that have to stop because they just can't take it.
But it's a small percentage, it seems.
But it's a relatively smaller percentage.
Okay. Todd, I don't remember who's next, you or me.
I think I am. I'm just going to ask this question. This is a question directly from a patient here. I had a DVT and PE 10 years ago. I work out 4 or 5 days a week, gained 40 pounds after menopause, tried Wegovy, Ozempic, Zep, many compounded versions due to cost. They did not work. Any idea why?
No, honestly. That sounds like a good question for an endocrinologist, not a hematologist. So no, I don't know. I do believe that like all drugs, there's probably a subpopulation where the drugs do not work. I will tell you that, there is something like inherent resistance. And so one thing we don't quite understand is why do some people have like such an issue with obesity and being overweight? It is not about being lazy. There's so much stigma associated with being overweight or having extra weight. And part of it is because they're like, oh, well, you could just like exercise and lose it. And yes, maybe if you exercise like 8 hours a day, somebody could lose it, but like not everybody can exercise for like 8 hours a day or can or needs to. So I think there is something inherently different. And so like with the drugs, the fact that drugs would work different in different people is not at all surprising. It's sort of expected. I would say like there's a mean you expect 25 pounds of weight loss in most people. But even on the studies, there are people that could not tolerate it, that it did not work, that had to stop. Of course, there's an alternative, and that is, something that has been shown to work well is like bariatric surgery, but that's like, reversing the way somebody's organs are. And again, word of caution is when you're on an anticoagulant, sometimes it affects the way DOACs are absorbed when you've had bariatric surgery, when you have bariatric surgery. So it's certainly something that needs to be discussed and thought about, especially in a population like this.
Well, I think a lot of patients wish that there were more doctors like you who explained it like this instead of just saying, "Look, you're too fat. You need to lose weight," and then that's all they say, and it puts them. That's not a good way to hear. That's
They
not
don't say anything.
that's not how to no that's not a conversation. So we really appreciate how you communicate with patients too, because that is extremely important how they come out of that appointment.
Yeah, for sure. Somebody wants to know how soon after having their PE could they start taking the GLP-1s?
I'm trying to think of this. I don't think they're linked. The only thing I would worry about is we talked about nausea to begin with, and like being on an anticoagulant is extremely important, and it's extremely important right after a VTE event. In other words, like the first 3 months / 4 weeks to 3 months are imperative that there's uninterrupted anticoagulation. We say avoid surgery, anything to stop it. And so I would worry about some sort of like if you're nauseous and you can't take your pills, I would say I would wait till you finish your 3 months or 6 months of anticoagulation, but I'm using common sense, not data here to suggest that. But I don't think this, like I said, I don't think there's actually think there's an interaction between the agents. And so I don't think there's a reason not to, except for if you're nauseous, you're less likely to take your pills. If you're not going to take your pills, you definitely don't want to not take something as vital as an anticoagulant right after a PE.
Yeah. I'm looking at the weight loss of some of the folks that have just the numbers. I mean, it's really amazing how much weight some people have lost. I mean,
Inspired.
yeah. I mean, it's really incredible.
Yeah, and then the question is, do you actually need to lose that much weight, right? Like, so like, there are people that like don't take it every week now. They go back on the lower doses. There's this, as much as, I mean, I care a lot about how I look like, I'm like, just like every other person, then I have to remind myself that I'm taking a drug that's expensive, that has side effects, that's needed. Like, there is a question of like, what is the goal here? What are you trying to achieve? One thing I wanted to mention that I didn't is something that comes up a lot with endocrinology is that there is this worry that you're losing muscle mass as well as fat when you're just not eating and if you don't exercise. So it is very important, to your point, to like go to the gym. You can just lose weight if you just stop eating, but like starvation is not a solution. And so you have to be careful about like how much protein you're eating. And it's almost more important to see a nutritionist and more important to do strength training when you're on the drugs, because you want to make sure you're maintaining muscle mass and keeping up with bone strength.
Yeah, no, that's
especially if you're going to be on it, which is the way the drugs are designed for a very long time / indefinitely. At least that's what it looks like for now.
And the older you get, the harder it is to maintain that.
Yes.
I mean, just trying to keep up with lean muscle at 61 years old, it's not as easy as it was when I was 40, right? So I have to work a little bit harder.
Yeah. And then if you're female and you are in menopause, then you have to deal with bone density and loss of muscle mass as well. So a lot of moving pieces here.
I mean, it's clearly it's a very effective adjunctive therapy for weight loss, is sort of like how I would think of it. And, you want it to work for you, not the other way around.
Right, exactly. Somebody wanted to know if there's a difference, if you're on an anticoagulant, does it interact? I know you said it doesn't interact, but is there any difference in terms of which anticoagulant you're on in terms of the weight loss itself? Like, does it work better with apixaban versus rivaroxaban versus warfarin, or is there not enough data to?
A, I don't think there's data, and B, I like, just based on how those drugs work and how how both the drugs work, I do know how anticoagulants work, and I'm diving into the world of GLP-1s. I would not imagine that there is any logical reason for there to be an interaction like that. Because it sounds like the question is, would I lose more weight if I was on, say, Proac as opposed to low molecular weight heparin? I don't think that's how it works.
Okay. Todd, any other questions on your side?
Well, a couple things that popped up. I mean, so Dr. Patel, it really doesn't matter if you're on anticoagulants for life, long term, or if it's just, short 3 to 6 months. I mean, there's no difference there, right? There's no higher risk taking these injections just because you're on it for life, right?
No, I don't believe so. No. I guess the short answer is no. Again, no. I don't think anybody's looked at this, looked at people on anticoagulants on 3 months and 6 months, but you can't look at everything when you're, in the end, you make clinical decisions based on like how you know agents work and risk factors work, and you sort of make conclusions. And so I don't think so. Again, I think like the short time right after a VTE is probably not the time you want to have surgery or start a new drug unless you absolutely have to, because it is imperative that you have uninterrupted high quality anticoagulation right after. It's also important afterwards, but like the vital time is like right after a clot. So that's probably not the best time to start something new. But no, I don't think that there is necessarily sort of a difference in somebody who's on an anticoagulant long term versus now. I mean, it would be interesting to see that. I remember when I showed this to some of my colleagues, they were like, yeah, that's, why that's important is because we always think about risk factors, and you try and think of, as most of you guys who've had a clot before would know, try and think of like, what are the risk factors that we can reverse and what are the risk factors that are irreversible? Because that actually plays into like, how long does somebody need to be on a blood thinner sometimes, right? Like, so if you have an irreversible risk factor, it sort of implies that you probably do need to be on an anticoagulant. And obesity, even though it is always we think of it as reversible, it's a very difficult to reverse risk factor. Like, there was no sort of way to sort of reliably believe that somebody would like lose the weight and keep it off. But if GLP-1s are the answer to that and are in fact clinically, as shown in this study, and hopefully confirmed with other studies, reduce the risk of ET, maybe that changes that paradigm. And so maybe there's, it supports like going on a lower dose of a DOAC for long-term prevention. Besides the fact that, obviously having a lower BMI, a lower dose, there's this dose and obesity that's always been a problem. In fact, DOACs, we worry about using DOACs, at least in the short term when somebody's extremely obese, because you're worried that it's not going to be enough anticoagulant. It's sort of like something that we think about. So you do want people to be at a healthier weight. And maybe there are people that you can go down on now because they've lost their weight.
Right.
Again, these are ways we can think about it. I will say some of this is sort of implied, or we're sort of extrapolating, or we're using logic, and that's not always how you want to make clinical decisions. But it comes in, and it's opening these interesting questions and doors that so far we sort of didn't really think of as highly achievable within a year, which seems to be the case. I mean, I'm not looking, but I'm like looking at all the comments that are popping up, and all these people that 50 pounds and 60 pounds, like you were saying, Leslie, and that's to have an intervention that actually works effectively and reliably.
I mean, it's amazing. I'm blown away by the folks that have done this. I mean, kudos to them.
No doubt.
So I'd like to get a commitment from you, Rushad. We've had so many comments and questions about this. And I know we can't be on here until 10 o'clock tonight, even though I would like to be. What I'd like to do is if people have questions, send them in to us, and then perhaps we could do a mini PEP in the not too distant future and answer some of those questions for folks, because this is going to be an ongoing topic. And again, we're not here to advocate for any particular drug. We are here simply to give everybody information about something that's out there that may help with, weight loss. I'm like you. I'm like this with my weight during my lifetime, and may need some help here. So, I'm going to take this seriously as an alternative and have a conversation with my PCP as well. I think before everybody gets going, we do have some exit poll questions, I believe.
Yeah, I'm gonna go ahead and read those, Leslie, when they pop up. And also thanks to Taryn and Jen back in the trenches who are working behind the scenes. They always make everything run so smoothly. So here you go, folks. Do you feel you understand why it is important to maintain a healthy weight to avoid blood clots? Single choice, yes or no. And do you feel you have learned how GLP-1s work to help lose that weight? Single choice, yes or no. Answer those real quick and we'll fire off the responses.
I hope yes.
Just takes a second. Here we go. So do you feel you understand why it is important to maintain a healthy weight to avoid blood clots? 100% said yes. Love hearing that. I think we're all on the same page. Do you feel that you have learned how GLP-1s work to help lose weight? 96% said yes. So good numbers, Leslie.
I still struggle with trying to understand it. I need to do more homework on my side, but I learned a tremendous amount tonight. And so, Rushad, thank you so much for all of your great work that you're doing.
Thank you for having me.
All right. Good night, everybody.
All the best.
Good night.